I'm Tony Denuzzo. Many of you know me. I'm director of the East Texas Geriatric Education Center, and I welcome you to this third session in Geriatric Health Literacy, this active learning series. We're going to be covering two topics today. The first part, and for about an hour and a half, is going to be on knowledge of health insurance in older adults. And the second part is going to be on looking at health literacy issues and communication with different populations in nursing homes and older prisoners. So some very interesting possibilities for discussion and things that we may not be too familiar with. I'd like to acknowledge our partnership with the East Texas AHEC, and that's been very valuable for us to reach our target population, which include 4 AHEC regions that we'll talk about in a minute. This series is part of a larger series of 5 areas of topics, and it came about as being the main objective for this Geriatric Education Center. Health literacy seemed to be an area that, as well as being on Healthy People 2010, was an area that HRSA, with the funds the GECs, really needed to focus on. And we're looking forward to our future presentations in May. Lee Grumbles, many of you know, will be doing most of this, talking about ethics as well as difficult topics and breaking bad news. And then we're going to end the series in June looking at the role of the interdisciplinary teams and as well as the role of culture on health literacy. And just so for your information, this is not going to be the end of it. The purpose of this series was to provide real basic information and background on health literacy, since it was an area that not many people were familiar with, but it is an area that is obviously important to provide effective health care, especially for older populations. So we're in the process of submitting our next year's proposal that will start in July 1st for our next budget year for the GEC. And that will include a series similar to this, 5 sessions, but it's going to be on more advanced topics. We're going to take what we're doing with this series and really expand it. We're going to look into more details, more nitty-gritty, more case studies, more scenarios. We have the possibility of working with Karen Sauter. Dr. Sauter is she's a medical director for the Standardized Patient Program, and we'll be working with her to bring in possible scenarios and patients, volunteers, to act out some things in terms of communication and how we do that as health professionals. So a lot of good things to look forward to next year, as soon as the funding comes through. The agenda for today is I will be providing an overview on knowledge of health insurance on older adults. I will tell you right off the bat, I am not the expert on this. There are maybe 3 people in the country who know about this area. And I'll be talking about their studies and overview of where we are with some of this information that seems pretty basic and important, but really we know very little about it. We'll have a short break around 1:30 or so, and then we're going to have a panel of, I'm going to moderate with two speakers, Diane Helliker with School of Nursing, and Jim Mann, who is in Lamar University. And Diane will be talking about looking at health literacy issues and communication with nursing home residents and families and staff in long-term care. And Jim Mann will be talking about dealing with the prison system and correctional settings for health care, particularly about older prisoners. That will be a relatively informal panel discussion, and it will hopefully have a lot of feedback and good talk back. All right. So, any questions so far? All right, good. Okay. As I mentioned, we are teleconferencing to 4 of our affiliates, and we have Lamar University, Lamar University in Beaumont, Stephen F. Austin in Nacogdoches, Baylor University Waco, and University of Houston Victoria. I think we're also trying to connect, if we haven't yet, to Ocean View in Texas City. And to give you an idea what they look like, we can do that. And there they are. We have, if I can get this right, Lamar University, Piney Woods? Yeah, yep, they're waving ahead. Piney Woods. I'm sorry, Pecan Valley, Victoria. This is Piney Woods right here. That's Mark. Mark Scott, our A1 AHEC coordinator in Piney Woods. Yeah. Yeah, he's great. We really have a lot of fun. Yeah, we're becoming more relaxed as we go through all this. And finally, we have Baylor University in Waco here. They're waving. That might be Amanda. No, it's not. Oh, I'm sorry. Is that Ocean View? No. Okay. Well, that might be Baylor.
We're top right, Tony. Top right.
Oh, this is Baylor. No. This is Baylor. Okay, I'm doing great. They change it on me every time, and it's like, wait a minute. Okay, so I know we have Piney Woods, Baylor, Pecan Valley, and this is Lamar, I think. Okay. All right. They look different. Okay. Oh, there's Jim Mann. Okay, I got you. All right, so we're set. Okay, now if you'll mute, and we'll move forward here. All right. We have a number of handouts and some paperwork to deal with. Something that's going to be really important for the GECs is to keep track of our participants. And we have specific data that we need to report our progress reports. And there is a participant profile list. If you haven't filled one out yet, please do. If you have already, don't worry about it. You don't have to fill out another one if you've returned from some of our other sessions. There's flyers for our next sessions coming up. And finally, CE credits. We are offering 3 credits for continuing medical education. And there is, all you really need to do is fill out the attendance and evaluation form for each of the speakers, each of the sessions that you attend. And fill this out and give it back to me when you're done. We also have offering continuing nursing education credits for RNs. And this is the packet for them. Fill this information out and get it back to me. It's really important for everyone to sign in. And if you can, fill out the general evaluation form for this session so we can get some feedback and improve as we move forward. All right. All right, we're also offering CEUs for social work. And that is in the same packet, same evaluation form as with the CME. Okay? For the social workers. All right. And we should also have lots of handouts for the articles, some background information, as well as copies of the slides for the presentations. All right. So any questions? We're all set to keep going. Oh, okay. Also, we are offering CEUs for physical therapists and occupational therapists. The main thing is to fill out the general evaluation form for them and get it back to me, and to sign in, of course. A lot of information that we have available for geriatrics is on our new website. Take a look at it. It's filled with a lot of good information that we've done with previous programs and lots of upcoming events and links to lots of information that we try to cover on a regular basis. In terms of what we wanted to do, something that came up when we were going through our program planning was in terms of insurance for health providers, something that might be real important is to look at ways of optimizing reimbursement for health providers. And while that's important, and when you deal with coding and lots of other issues in terms of getting the forms in, it's hard finding speakers. It's hard finding people that could talk about that area and feel comfortable with it. It's even less likely to find someone to talk about health literacy and insurance. I did contact some speakers in Washington, and there is quite an honorarium. Not to mention, I probably have to book them about 6 months in advance. So it ended up that I would do this. And I will send a disclaimer that I don't consider myself an expert, particularly about medical insurance, but I am learning a lot on this learning curve in this crash course in health literacy and insurance. So the main thing that we want to try and do is provide an overview of the methods, the assessments that have been used to measure the level of insurance and knowledge of insurance for Medicare beneficiaries. That might be the bottom line, but what I want to do first is, for those that haven't participated in some of our previous sessions, talk a little bit about what health literacy is. All right. This might be a repeat of some other information that you may already know, but for those that are not familiar with it, it's the degree to which individuals have a capacity to obtain, process, and understand basic health information. And this is very important. If there are services that they need, can they access those services, and can they make the appropriate health decisions that are needed for good health outcomes? Okay, that's the bottom line to it. And that came into Healthy People 2010. There are several components to health literacy. If you look at the Speak mnemonic, obviously speech, how health providers speak and communicate with their patients and how it is received can make a big difference in terms of whether information is successfully given and obtained. The perception, how the patient and caregiver perceive both the verbal and written work and information. Is this actually done by health providers? And how do the patients perceive their attitudes towards them? Do they move through pretty quickly, and do they feel comfortable to ask questions, for example? Level of education is obviously a component of health literacy, and also access. Access is not so much getting into the parking lot, okay, or making a call to make an appointment. It's how the environment is within the medical setting. Do they feel that they can not only get into the medical setting, but what about knowledge of the system? Okay, and here health insurance obviously comes in quite a bit. And then finally, knowledge in terms of being able to carry out what they need to do if they're given the information. And please feel free to stop and ask some questions, because I might have a tendency to go through this too quickly because I feel there's a lot to cover. Okay. So how was health literacy first examined, assessed? The role of it came on top of the National Assessment of Adult Literacy, and they actually looked at literacy from the beginning in terms of how do you determine the level of literacy in the United States overall. And that was done in '92 for the basic prospect of making sure people could find a job. Health literacy really didn't come around as being part of a survey for assessment until 2003, where the NAAL looked at 26 items and did a certain amount of scoring that based on 500 points, and made these categories to put people in certain levels of health literacy. And
General people?
this was a general population. Okay. This was not just geriatrics. Okay. These were 25 years of age and older, 19,000 subjects, 25 and over. And these were the 5 areas, and you can give a little bit of an example of those with a below basic. The best that they would be able to do is a task of circle a date of a medical appointment, for example, on a hospital slip, okay, an appointment slip. Okay, then there was basic, intermediate, and proficient with these types of things that they would be able to do. It's interesting that in intermediate, those are those, for example, that could do a task to take their medication as prescribed. And that's intermediate. Okay, if you're thinking that most may have basic or below basic, this could be a challenge for patients if you just know that much. Okay. Overall, the level of, it didn't come out too well. Sorry about that. But anyway, the level that were below basic or at basic was approximately 1/3. And so that is something to be concerned about. 1/3 of these subjects had below or at basic level of health literacy. This could be something that would need to be addressed. One thing that was very important was in terms of being able to correlate the level of health literacy with overall health. It was pretty much hypothesized that those with poor health would also have lower levels of health literacy. And that's what this shows. 42% of those with a below level of health literacy also self-reported their health as being poor. And it more or less was a linear progression. Those with excellent had higher levels of health literacy. And this was controlled for age, this study, this information. So the bottom line for this was that 12% overall, while they are proficient, majority had some needs in terms of needing to look at their level of health literacy and how they could prevent disease or manage their health. 14% were below basic, and that translated in terms of numbers and proportion to about 30 million people in the United States. So this, and mind you, this is very early. This is preliminary. This gave the first indication that health literacy was something that needed to be looked at in a much broader sense and maybe with more detailed studies. So why was this also important? Well, when making healthcare decisions, it's important to be able to understand what you're being told, to make appointments, to whether you're taking medications correctly, follow directions, all these types of things. And we're going to see with understanding insurance, filling out forms, this is obviously something that needs to be looked at. And for health outcomes, those with lower levels of health literacy were less likely to use preventive services. They were more likely to have hospitalizations and use emergency services. So it was really something that needed to be examined, and it has been. Those that are high risks for low levels of health literacy are the usual suspects. For the most part, the elderly, those from immigrant status, minorities, as well as disabled, for several variety of reasons. Not all would have low education, but there may be a language barrier combined with education issues. And impairments, especially with the elderly, obviously with vision and hearing as being a major barrier. And there are very many factors that go into whether health literacy is actually affected. And with an older population, I mentioned vision and hearing, but also, as was talked about in our first session, health professionals need to have empathy to be able to understand that you have a patient maybe that is in distress and in needing of some attention, and do you have the time as a health provider to give that empathy and understanding? And for an older population, we talk about elder speak. What that is, well, dearie, now, dearie, everything's going to be fine. And so what type of terms are being used? And these types of things, certain terms really turn off older patients. And you probably have examples that you may have seen with this. But from what I've read, one of the most challenging factors that affect health literacy is the feeling that a patient may not want to disclose that they don't understand. All right, this level of shame and embarrassment. And how do you get past that? How can you recognize that that is something that is a barrier to them understanding directions or the information they're being given? And finally, individuals with poor literacy they're uncomfortable about whether or not they are able to read. And so how do you develop strategies that can compensate for that lack of literacy? So one way that we can do that is by doing an assessment. And there are limited tools out there. The ROAM we've talked about as being a rapid estimate of adult literacy in medicine. It's basically word recognition about 20 terms, and they will verbally say that I understand this many words and this many terms. They don't necessarily have to go and define them. They just have to tell you that they recognize what the term is. So there's really no check on that. So but it is quick and it may give some idea of whether they can understand a certain level of terms. The TOEFL, the short form for Test of Functional Health Literacy, is probably the most used in studies. And it's reading comprehension. It's short little sentences with a word missing, and then they would just fill in what the word is. And it usually would probably try to make some sense of what that sentence comes out to be, and that gives an indication. But it does take longer to do a test like that. And that's a barrier for many people. To take 20 minutes to do a test like that is probably not very feasible during a hospital visit. So many of these assessment tools really haven't been evaluated very well. They don't cover much of the types of things that really go into components of of literacy in general. There's being able to read, and there's also then the ability to comprehend. Many of these tools don't do both. And then, of course, time. How much time is available to actually do these assessments, and how many health providers actually do them or give an attempt to do them. So these are the conclusions for the most part. There are certain ways that we talked about earlier about how to simplify labels and the types of words that are being used within the medical clinic, and the talk back. When you're giving instructions, have the patients give back the instructions to you. We talked a lot about this, and it's not the purpose of this session, but to give you an idea that this material and the expertise for this are becoming more available over time. But it is a very common problem and something that hopefully we are moving towards doing something about. Okay. So, any questions about the overview? Before going into trying to determine how much a patient knows about their insurance, in terms of health literacy, I found that I couldn't just go into those studies. I had to first get a pretty good idea of overall how do we identify patients or subjects with low health literacy skills, regardless of whether they know anything about insurance. Okay. And that's what this second objective is, identifying those with poor health literacy skills. And there are 3 studies that look at this. The first 2 actually don't look at insurance groups per se, but I did want to point out that with these studies, notice in '99, this was the very first study that I'll describe. Guzmarian is with Prudential Insurance. And they did collaborative studies with CDC in Atlanta. So right off the bat, there may have been, what motivated this information through an insurance company was really pretty interesting. This was not done through a hospital setting or a hospital team. This last one, differences in health literacy among subgroups of Medicare beneficiaries, McCormack is with the CMS. And the Centers for Medicare and Medicaid Services. It's a government agency. And this basically is what we know about health literacy for certain subgroups, and what we might know about level of knowledge of insurance for Medicare beneficiaries. So this first study by Guzmarian in '99 had the objective to determine the prevalence of low levels of health literacy among the Medicare enrollees in a managed care organization. It was a cross-sectional survey and looking at 4 Prudential healthcare plans in 4 different sites. It looked at Cleveland, Ohio, Houston, and South Florida and Tampa. And it was a face-to-face interview. Over 3,200 subjects with new Medicare enrollees, 65 or over, and it was conducted in 1997. So this, obviously dated, but I wanted to give this being the first study. And they did look at, they did have an English and Spanish versions of the survey. And so it was given mostly, obviously, in English, and they had 304 who had Spanish as a first language. Their assessment measure was with the TOEFL, looking at functional health literacy. Now, what was interesting about this was how they would determine what the scores meant. This hasn't been standardized. So they looked at the two parts of the TOEFL, one being the reading comprehension, was 36 items. Again, we might be looking at a pretty long interview test looking at some of these questions. And so it measured ability to read and understand prose and passages at a certain grade level. And so, depending on the instructions, there were different grade levels depending on the types of scenarios and passages that were used. The second session was looking at numerics. It was just 4 items looking at test ability to comprehend directions on medicine, monitoring blood glucose, and keeping a clinic appointment. The scoring was tried to add up to 100 based on reading comprehension, and they multiplied the number of items to come up with 72, and then multiplied the number of items for the numeracy by 7 to come up with 28. So they had a nice round number of 100. I think that's great. You really have a nice number to look at. There wasn't a lot of explanation on how this was actually determined.
Higher number, good.
Yeah, higher numbers were better than lower numbers. Right. Maximum score, the best health literacy level you could achieve was a 100% score. Basically, the categories in terms of where the scores came out was also pretty much arbitrary. And if you had a score between 0 and 53 out of 100, you were considered to have inadequate health literacy. And it would indicate that you couldn't really read even the simplest materials. Instructions were beyond comprehension for the most part. Marginal was a much narrower range, between 54 and 66. And they obviously had a little better idea in terms of being able to understand Medicaid, insurance, and different passages that had to do with those types of areas. And then adequate was everyone else that had 67 or over in terms of the scoring. Obviously, lots of limitations, lots of things that you could be suspect in terms of how this was done, but they were trying to set some ground rules, some guidelines to begin with, and then go from there. So with the results, turned out that overall 33% or so had inadequate or marginal health literacy. They combined those two groups. All right. They didn't separate out in terms of how many had inadequate and how many had marginal. It was basically a third were either inadequate or marginal. And those that were Spanish-speaking, those 300 subjects, over half of them had low levels of literacy. Now, how much of that was also because of a language barrier? Again, even though it was in Spanish, how was it translated? Okay, how well was that translated? So in the prevalence for inadequate and marginal health literacy among the English speakers ranged from 26 to 44%. Right, and this was the overall. Reading ability declined with age, as was expected for the most part, and a lot of this may have been due to cognitive impairment, although it was adjusted for education and impairment. This is kind of interesting, though. The odds ratio of having inadequate or marginal health literacy was 8.6, meaning that those with inadequate health literacy were 8 times as likely to be 85 or over compared to those that were 65 to 69 years of age. Right, so there was a very strong age component in terms of a level of health literacy for this population. What was also interesting is that there were geographic differences. Not saying anything against Cleveland, all right, but they had the lowest health literacy scores. And that would be kind of interesting to look at, because geographic areas in terms of how information is given, it could be different by geographic area. But we also did find some health differences in race, where blacks and Hispanics had higher rates of low literacy. Yeah, higher rates of. education was, of course, lower associated with a level of education. But if 17% of the respondents had a high school education and 10% had above high school education, they had inadequate health literacy. So it really wasn't an indication that education, number of years of schooling, would translate into having higher levels of health literacy. So this was the first study that examined functional health literacy in a population of Medicare enrollees. And the thing I mentioned about geographic differences, it was important to look at how the healthcare system delivers health literacy levels based on the setting, and that you really can't rely on overall national data. Okay? Each area seemed to be individual in terms of the characteristics of that geographic area.
The population they are interviewing is Medicare enrolled people of a
Beneficiaries.
certain company, right?
Right. For a managed care beneficiary. The second study was also by Guzmarian, and this was the same group. What they basically did was just to bring out one other component of that data, and it was to look at the amount of social support that those with these Medicare beneficiaries actually received. And how was that in terms of relation to the care that they also were obtaining. So you would look at the amount of information that was available, and they would be given reminders to obtain annual care and preventive care. Not to go through a lot of the methods, it was basically the same group as I talked about the study before. And compared to those with a higher level of literacy, those with low literacy were more likely actually to receive general medical information and support. And so I was kind of wondering, like, well, okay, is it because health practitioners felt the need that this group needed more information and more resources? And it was very general information. But what was important was that the amount of tangible information, the useful information that those received that had low levels of literacy was not as high as those with higher levels of literacy. So while they're being given, those with lower levels of health literacy are being given information, it's not necessarily information that they can use. Okay. So the health reminders support was associated with more doctor visits and a lower likelihood of a hospitalization in the high health literacy group. All right. So that may not tell you a whole lot, but it does give some indications that there are aspects of health literacy that were shown that those with low levels of health literacy could be geographic, based on age, and then information that they're given is different than those with higher levels of literacy. So let's look a little bit at assessing the gaps in insurance and knowledge. Any questions so far? Okay. How are we doing on time? Okay. We're doing good. All right. Basically, to assess the level of knowledge among health beneficiaries, the main groups doing this are the Centers for Medicare and Medicaid Services and the Medicare using the Medicare Current Beneficiary Survey. The CMS, they conduct several different types of educational activities, and their main purpose is to try and inform Medicare beneficiaries about available health care plans and to increase the awareness of what resources are available. And to be able to evaluate and how effective they are, they need to measure just how much their beneficiaries actually know about their insurance. And but this is really only recently added to this Medicare Current Beneficiary Survey in terms of the amount of insurance that they actually do know, because the main goal And the bottom line is whether or not the beneficiaries have the level of knowledge they need to effectively navigate the Medicare program and make informed decisions about health plans. I don't probably have to tell you that the healthcare system is pretty complex, and insurance is a pretty difficult system to navigate through. And my goal was not so much to give an overview of insurance for older adults. We have lots of information available for that. But I did want to give you an idea of what areas and what's being done to examine and assess the level of knowledge of health insurance among older adults. So, let's see. There was this study by McCormick with the CMS that assessed knowledge of insurance and differences, looking at different subgroups of healthcare beneficiaries. And the objective was to look at this group and determine what factors predicted the level of health literacy. And as I mentioned, they used the Medicare Current Beneficiary Survey. And this survey was developed by the CMS for this purpose. And you have actually a copy of it. And this is going to be an active learning, right? So I'm not going to be testing you in terms of what you know about health literacy or insurance. But what I will be doing in a little while after we go through this information is we're going to be breaking off into little groups. And there's going to be some reactions to some of this information in terms of like, well, this is a problem. What do we do about it? Is it at a policy level? That type of thing. So if you look at, I have one of these handouts with looking at the MCBS Medicare knowledge. Okay. There's a lot of stuff you have. Okay, and if you go to the this first two pages were general questions about insurance. But if you look at table 2.3, I could bring this up here if you'd like. All right, this thing right here. Okay, this is the health literacy quiz for insurance. Oops, well, actually, those are the answers. If you look at these, there's 10 questions that look at terminology. All right, which of the following two statements defines the term appeal, for example? Okay, can they define that term? Okay, and they have other ones, other terms being define term assignment, define formulary, preventive care, generic drugs, outpatient care, provider network, primary care doctor, what a Medicare deductible is, what Medigap is. All right. Those are the 10 terminology questions that they ask. Okay. The right answer is in italics. And I'm so glad, because I would be spending the rest of my life trying to find out what the right answers are. No, but hopefully not. Okay, and that's only the first part. All right, so be able to do that. The second part have 17 questions on reading comprehension. And those are on the second page, 2.9. All right, and this gives you an idea of, well, is information available in Spanish, looking at an 800 number, a Medicare, yes or no. Okay. So mind you, a lot of these, you have a 50% chance of getting it right, even if you guess, right? So what did they find out? Well, the next page on that handout gives you the percentage of correct answers that they gave. It's actually on the back for the terms, 55%, for example, didn't, could only correctly define Medigap. Okay, while 80% were able to define appeal correctly. So that gives you some idea. Okay. Where these questions come from? Well, they were taken out of the Medicare and You 2001 handbook. All right. I don't know how up to date this is. Medicare insurance has changed a lot since then. But are these terms still valid? Are they still being used? That's one thing to think about. And it was designed to try and interpret, if you can determine a Medicare claim, looking at dual eligibles, exercises related to choosing a plan. And the last part I'm going to talk about is the importance of how to do good decision making in terms of determining what type of health care plan an older patient can be most useful for. And this was for 1,000 subjects that were 65 and over and were in Medicare beneficiaries in the community setting. Now, this was basically a new measure in terms of how to assess health literacy. It was the first one to actually look at terminology in insurance and scenarios that would be given to see how would an older person be able to choose their health care plan. Terminology was definitely a problem. Defining network provider was pretty low. Formulary was very low. All right. 90% did know more or less what a primary doctor was. Okay. But only 50% could actually look at the purpose of a personal plan finder, or 60% could report to Medicaid as a joint federal state program. Overall response, they had difficulty interpreting data on claims forms. And how much do you pay a doctor? How much are you responsible for a deductible? These are things that could be barriers. So when I was thinking about this, I was thinking, okay, so what does this mean? I mean, there's no data out there that actually shows that this will have an impact on whether or not a person seeks care. If they don't understand or can interpret their insurance needs and how much they actually need to pay, will they actually seek care if they're not quite sure that they can afford whatever it is that they think they have to pay? So seeking care and whether or not that's a good decision is a possibility, a possible barrier for this. Right. So in terms of subgroup differences, it was, again, those subjects that had lower levels of health literacy were those who were disabled, older age groups, again, minorities, those with less education, and those in fair or poor health. Right, the same groups as before. And those that were more or less determinant of this low level of health literacy with less education and income, non-whites and the older beneficiaries. So, as I mentioned, there's really no reference established for how much is enough knowledge. Okay, we really don't know that yet, because this is only starting out, but there's a lot that still needs to be done. What is the cutoff score that actually shows that this knowledge is adequate to make the right health care plan decision? Okay, it's very important. Okay, and what is the minimum knowledge that's actually needed to be able to maneuver and navigate through the healthcare system? Possibly, many people here are able to do that, but can, the average person in the community be able to do that? Maybe those.
Like the taxes information changes every year, so you can never achieve a high level of knowledge because it's ever changing.
Yep.
Whenever you're gonna contact any of those companies or do any of those things, something new has happened. So your knowledge will also always be below. Because nobody can keep up with the changing environment, the changing regulation, the added, and things is very hard for people.
Right, Maria, and we know that. So what I want to try and do after I have a few more things to show you, is that I think it's going to be really important, besides just giving you a lot of information that's out there, to break off and discuss that. what is it a broken system? You know, is it a system, is it the only way that it needs to be? Is it and why is that? And at what level, of whether legislature or where, can the system be modified so that the average Joe Blow can understand what they need to understand to get proper health care? To me, it's pretty much the bottom line. And so then you have to be aware of that some patients may not be very aware of what they need. And so how do you what kind of message do you give so that they're able to do this? And it kind of brings me then to this last part in terms of improving healthcare plans to make good decision making. This was spearheaded by HCFA, okay, looking at ways to improve healthcare decision making. And they would look at, at first was a national Medicare education program and the use of the Medicare and You handbook. And that there were obviously deficits that are implicit with age simply by getting older and being able to hear and understand the information. Not with everyone as you get older, but for most. So cost was also a factor that would impact whether or not they could make a proper decision on a certain health care plan. How much cost was involved? There was obviously financial limitations and what was available to them in terms of choices and benefits that they would qualify for. The demographics were obviously factors that could affect decision making. And where do they get their information? Who makes the decisions? Can they make their own decision? Do they rely on their doctor to tell them what the best plan is? Are these choices limited? And is the information that they receive, is it disseminated in a way that they can understand? So, with this study, looking at healthcare plan decision making with new Medicare information materials, again, that familiar name with Lauren McCormack over at CMS, looked at information as disseminated, and the clarity and conciseness of it was much more effective than whether it was a whole lot of information, meaning more was not necessarily better. All right, if it was something easy enough and concise enough to understand, it was better. Healthcare decision making, in terms of this population, for this study, showed that there was a negative effect that was attributed. They looked at this handbook. Look through the handbook and tell me what information you understand. Because they did not feel that getting this healthcare plan change would actually be happy with their current plan. Okay, meaning that they were given a message that they did not need to change the plan if they were happy with their plan. Okay? So that was a message that really needed to be taken out because then it became a promotion. They were selling something, and it was immediate turnoff to this information. Yes?
Was there an assessment of how many people are happy with their current plan? That would have been good to know that nobody's happy.
Yeah, they probably could have guessed that, but I didn't come across information that actually would ask that specific question, whether they're happy with their current plan. But yeah, probably not many. So finally, the last two things, the last thing I want to talk about is looking at this study, identifying Medicare beneficiaries with poor health literacy and using a short screening test. And the main purpose of this was not only to determine whether a short screening test was feasible, but can you actually predict the level of valid measures for health literacy using that screening test? And what I'm going to show is that it was, with this design, it was a small number of Medicare beneficiaries of only 293 subjects that were recruited in Oregon in the senior center group. So these were older populations, and there was quite a bit of information about it that I wanted to bring up real quick. If I remember what I did with it. The average age of the participants was 76. Majority, this was a higher level of education group. All right, over a third of them had a college degree or higher. and the participants were better educated and report better overall health than most. So this was a little skewed towards a more affluent, better educated group. And these were the questions that they were asked. With a Medicare HMO, can you go to any doctor, for example, in a hospital in the United States for routine care and be covered? True or false? You know, Medicare pays for flu shots. Some of these same questions that were with the CMS that looked familiar from that handout I gave. And when asking about making decisions, have you sought help for a Medicare problem or a question? If yes, from whom did you get that information? Was it a family member, friend, or counselor or advisor? Okay, and how did you obtain information to make a decision about your Medicare insurance? And this is kind of interesting. They would be asked, I prefer not to have the responsibility of making decisions about my Medicare. I don't want the responsibility. And when it comes to making decisions about Medicare, I prefer to have someone knowledgeable decide for me. Just as a guess, do you think that those with higher or lower levels of health literacy would prefer to have somebody else be responsible for making their decisions about their Medicare? Lower. Exactly. Yeah. First, being able to understand information about their Medicare. Those with inadequate or marginal health literacy, this open box, over 60% had difficulty understanding information about their Medicare coverage. Whenever I make a choice about my Medicare, I worry that it will be the wrong one. 50% either inadequate or marginal literacy. I am more likely to make a wrong choice if I have lots of different options to choose from. Almost 60% with inadequate or marginal literacy. Big differences compared to the adequate group. As far as who would be responsible, as you guessed, I prefer not to have the responsibility of making decisions about my Medicare. Over 50% with inadequate or marginal literacy compared to less than 20% with adequate literacy. When it comes to making decisions about my Medicare, I prefer to have someone knowledgeable decide for me. Over 70% with lower levels of literacy wanted someone else to do it for them. Okay. That should be a little eye-opening, I would think. But maybe not surprising in the long run. You see why this is difficult? Because what is, how do you grab hold of all this and say that this is kind of what we need to do to talk about it? And so that's kind of what I want to do now. We have about a half hour, and hopefully I didn't go through that too quickly, but you do have your slides if you want. And if you can, we're going to just break off into groups. The other sites, if you could work out having groups of 5 or 6 people max, we can probably work this out where look at ways to discuss healthcare providers in terms of how they could address deficiency in health insurance knowledge and attitudes. All right. To just talk briefly about what the setting in healthcare is like for these groups and what's available, and, you know, and how is it managed for the most part. We'll start with Diane. Real quickly.
Now, all of you should have a bibliography, so when I mention a study or something like that, I'll mention the name, and at least you have the information if you want to look into it. The other thing I've passed out, or the other handout I have, is the Nursing Home Compare, which includes a checklist for what are the qualities what are the quality indicators for a good nursing home, and we'll get to that later. But right now, again, briefly, there are today about 17,000 nursing homes in the United States. 1.5 million residents live in them. As of 2002, there were 36,000 assisted living facilities with 910,000 residents. That was in 2002, and that was a 49% increase over 1998 totals. So gives you an idea of the growth of long-term care in this country for elders. A lot of my research over the last 15 years is involved in long-term care, the transitioning into a nursing home, and then I follow residents for 3 months, the transition into assisted living, and I follow those folks for 7 months. And then I began to really look in detail at the relationships among staff and residents and their families in long-term care. And right now I brought my research into facilities in New York City, Illinois, and Texas, primarily in depth. Each long-term care facility is very unique. There is usually a medical director, an administrator, a director of nursing, who most often is an RN, not always. And she usually has 75% of the DONs, the directors of nursing, have an ADN, or associate degree in nursing, 2-year education. Most nursing personnel are LVNs or LPNs and CNAs. There may be a professional physical therapist. Otherwise, there are also restorative aides. There may be an occupational therapist. There may be a social worker, an activities director and her assistant, a consultant psychologist, and perhaps a geriatric nurse practitioner. The number depends on the size and ownership of the facility. In some corporate-owned facilities, one healthcare educator may be responsible for all the facilities. Some of those, well, we'll get to that. There are usually monthly in-service, staff in-services that cover topics such as falls, abuse and neglect, infection control, feeding techniques, wound care, medications, antidepressants, death and dying, communication techniques. I usually hang around for these in-services. And what I usually see is a group of very angry employees who must sit and listen before they get their paychecks. Now, those of you who teach realize that if you have a bunch of angry students, teaching just stopped. But that's the way it is. The majority of residents are Caucasian, female, widowed. The latest percentage who have some cognitive impairment is 90%, along with 3 or more comorbidities: cardiovascular disease, cancer, diabetes, arthritis, urinary tract infections. I usually count 8 to 10. 29% over the age of 65 are below basic health literacy levels. Only 3% are considered proficient. The environments vary from hospital-like appearance to lavish, homey surroundings, from quiet and peaceful to loud and noisy. Lighting varies. Turnover of staff, anywhere from 3% to 200%. That's usually the CNA, the LVN, the RNs, the DON, administrators. At one point, not too long ago in Texas, DONs were here for Their turnover rate was 6 months. Administrators were not far behind. The models of care vary as well. There are those now who are trying very hard across the country to put into place patient or person-centered care, relationship-based care, culture change transformation, thanks to the Pioneer Network that started in New York in '97, the Eden Alternative model, greenhouse model, team approaches, many different models. And from my standpoint, this area of practice is the most interesting and complex and challenging I have ever experienced in my 45 years of nursing. Beginning with my very first experience as a CNA at the Lambs Club in New York City, which is a home for old actors and actresses. And so I went in and heard wonderful vaudevillian stories, and that may have started my entire journey into long-term care. The facilities may be, even though, and going back to each one is unique and varied, the facilities, even though they're owned by the same corporation, same benefits, same mission statement, may be very, very different depending on who the administrator is. Each one is very unique. Okay, that's an overview.
Very good. Rosy in a way, but maybe not so rosy in another way. Okay. Jim, what about the correctional care setting?
Well, hi. Just want to give you an overview of the elder population in prison. And the elderly population has surpassed drug offenders as the most rapidly growing segment in prison nowadays. Over the past 10 years, the number of elderly inmates has tripled in size. And a recent survey said that there was about 113,000 inmates 55 years or older in prison. That's about 7.5% of the total prison population. The reason the survey identifies inmates 55 years and older as the older population is because we're seeing the similar geriatric symptoms in these inmates as you do in community examples of 65 years or older. And some of that has to do with just kind of a hard lifestyle prior to prison, as well as incarceration factors. There's a combination of factors why that contributes to the rise in the elderly population in prison. One of it is the nation as a whole is getting older. The aging of the U.S. population in general. Also, more activities have been declared illegal since 1994, the Crime Act, and that includes conspiracy for drug offenses, weapons charges, and so forth. Along with that Crime Act, more okay. Increasing in criminal sentences, felons getting longer time, and many states, including as well as the federal government, have abolished parole. Let me briefly describe some of the prison health in prison in general, just parole. And that varies greatly from state to state, as well as within the state, from institution to prison. For example, a lot of my background is with the Federal Bureau of Prisons, and when I was with the Federal Correctional Complex here in Beaumont, which has a UT&D contract, we have one MD for 4 prisons and at least one PA or RN for each of the shifts, and then the rest of the staff are made up of LVNs. Other Bureau prisons, they have public health officers and some direct hires, and usually there's at least one MD that supervises a PA and an RN on each shift. And this variation continues on with states. Every state has a different combination of how they try and utilize their health staff. But almost all the states have some form of a prison inpatient hospital for general surgical and psychiatric patients. So just like the one at Galveston for UTMB and TDC, Federal Bureau of Prisons has one in Springfield, Missouri, and another one in Button, North Carolina. An example of a small one is the Ohio State Prison. And at Lima, Ohio, they have a 239-bed specialized correctional medical facility. And out of 455 staff, they have 53 RNs and 36 LPNs to provide services. Some of the challenges and barriers in communication,
Jim, before we,
communicating health needs to.
Jim, before we get to that, Jim, one second, before we get to that, I wanted to just ask you real quick. I may have missed this. Are there special provisions or facilities for older patients, or are the patient care pretty much mixed regardless of age?
It's pretty much mixed regardless of age, unless there's a special program that's been put in place. Now, it would be similar to going to a community clinic that didn't have a special program for elderly patients. They would do their best to provide whatever services were needed, but for the most part, they don't provide a lot of services specialized for inmates unless they have a significant population of those inmates at that institution.
Right. Very good. Okay, well, we're going to continue with what you were going to get into the barriers for communicating with the older prisoners or with staff. That would be fine.
Now, a lot of the barriers are the same that you'd find with just dealing with inmates in general. And even though the inmates are older, that doesn't mean they've grown out of some of the criminal lifestyles. And so because of the criminal lifestyle, they present with a lot of variety of health needs. They're impulsive, they tend to take risks, they get into more accidents and fights because of that. They have this attitude that I'll do it tomorrow when it comes to responsibility about themselves, but let's do it now impulse when it comes to doing something pleasurable, whether it's doing drugs or alcohol or sex or anything that gives them an adrenaline rush. That's what they'll do first. And this lifestyle, as you can imagine, leads to a number of health problems associated with addiction, STDs. They have a history of infectious diseases, dental problems are a major problem. Anything that has to do with poor nutrition or complications from old wounds and injuries. And in fact, by the time people get into this prison and been there for a while, they remark that, this is the best health I've been in for a long time. The problems that healthcare professionals have in dealing with the inmates is that there's basically a lack of understanding by the inmates of the toll that they're taking on the body due to the lifestyle they're living. And that's because it happens so gradually, they just don't notice it until it blows up in their face, so to speak. There's also a lack of motivation to change because the old lifestyle is familiar to them, and a lot of times it's pleasurable to society. We also tend to manipulate health care people as well as other prison staff. And so the health staff gets cynical because they consider that all inmates are just trying to con them out of prescription drugs or work release or some other kind of benefit. And then you have the inmates' lack of planning and organizational skills in general. You have to teach them long-term planning, and that's kind of hard to do when somebody's long-term plans what I'm going to do this weekend. So you might think of inmates as being more like adult adolescents. They share a lot of commonalities. They don't consider consequences. They have that invulnerability attitude. Nothing's going to happen. They don't respond well to authority or being told what to do. So in a lot of ways, they are kind of like adolescents. Add to this that the coping response for a lot of the inmates is seeking the easiest way out of any problem. whether it's a health problem or an interpersonal problem, plus the attitude that if you do anything wrong, blame somebody else. So if your health suggestions, your treatment, your prescriptions don't work right away, then it's your fault. Now, elderly inmates, they mellow out somewhat, but they still share a lot of the same commonalities with the younger inmates. And so a short list of the challenges in dealing specifically with elderly inmates would be that they're susceptible to airborne and other infectious diseases because of the close confinement with other inmates. And they have, basically, they come in with a decreased immune system in the first place. As with other elders in the community, older prisoners have circulation problems, and they need specialized attention that's not always readily available in prison. Again, as you get older, anger, confusion, irritability may be present, and with an antisocial lifestyle, that's something that's fairly common throughout their life, but it gets may get increasingly greater as they get older, and anger, confusion, and irritability are provoked more frequently in prison than in others. And this can exacerbate mental health problems, symptoms, and other problems, interpersonal problems. Speaking of interpersonal problems, unless they have some money or they have friends, they're often targets by the younger inmates, and so they remain a little more vulnerable to exhortation, exploitation, and parties of abuse. And this can lead to increasing stress disorders as well, and in some cases, PTSD. Mobility issues are common. Prisons have a lot of built-in barriers on purpose, and that makes wheelchair access limited, and crutches and canes aren't given out very regularly because they're a restricted item as well. They can be used as weapons. Organizationally, it's also a challenge for the prison administrators to implement programs aimed at keeping inmates, elderly inmates active, both physically and mentally, because the majority of the programs are designed for the younger ones, because they are the majority. Nevertheless, their prison health is getting better. There's a case, Estelle versus Gamble, here in Texas, that became national back in the 1970s. And that mandated community standards for health care in prisons. And so, since then, health care in terms of clinic, equipment, services, personnel has gradually improved. And I think for the most part, most prisons are conscientious about providing adequate health care. However, as prisons gain more and more older inmates, the inmates with all the problems and challenges related to geriatrics, the need for in-house specialization of aging is going to continue to grow. The Bureau of Prisons a few years ago responded to the challenge by establishing a hospice and an inmate nursing home in one of those hospitals at Fort Worth. But with budget cuts and mission changes for that institution, that kind of melted away. And now the new geriatric need is supplied either as part of the general population in prison, or if it becomes severe, we may have to go to an inpatient medical surgical hospital.
In Salvadorian, British, Korean, Vietnamese, they may all be in the same nursing home working. Or, as I was very, very blessed to have a sociologist as one of my research associates, and when I first took her into one of our nursing homes locally, I said, you see, and I made a comment about, you see, there were a lot of Hispanic CNAs, and she said, oh, Diane, there are 10 subcultures of Hispanic CNAs here, and they're all working differently, and there is a hierarchy. And so she taught me a lot over the last several years about subcultures. And so Hispanic doesn't cover the diversity of the Hispanic staff. One of the articles that I put in the bibliography is by Munoz, M-U-N-O-Z. It's excellent, and he speaks of culturally responsible caring, culturally responsive caring, which is defined as actively developing a synergistic relationship grounded in mutuality and an intentional respect for a person's culture. Culture is profoundly tied to matters of health and health care. It says people learn from their culture how to be healthy, how to define illness, what to do to get better, and when and from whom to seek help. We have to really understand how important culture is. The staff and the residents bring their own personal and familial culture to every single encounter. So you have these two cultures coming together, and layered on that is the culture of the long-term care facility. It's very challenging. So let's see. That's one challenge. Another is, of course, the language problem that goes along with that. Now, there are some long-term care facilities in the United States that focus or serve one culture. In Lubbock, there's one only Mexican. And so all the food is Mexican, all the staff is Mexican, all the residents, they eat as family, and that works really well. In Chicago, I've been to Polish nursing homes, and that works real well. There are also Korean nursing homes. Those are the three I hear about most. In fact, I understand there is a Korean home, nursing home, outside of Houston. And so one of my colleagues who comes from Korea is going to take me over there, and we're going to see how that works. So that's really nice. And it's really important to understand culture from another. I was recently reminded, I always listen to aides, they teach me so much. If you're familiar with the Eden Alternative, where you're making a habitat of the home. Bill Thomas from Harvard started it in '94 in New York. And he had gone in, he was helping another physician who was the medical director, and he went into a nursing home to cover for him so the guy could take vacation. And what he saw appalled him. And he said the three tragedies in a nursing home, right? Helplessness, loneliness, and boredom. And he swore he was going to do something. And so, many years later, he certainly has done a lot. A lot of homes are now Eden Alternative homes. You are allowed to bring a pet. Every resident may bring one pet, cat, dog, bird. If you don't have one, you may usually pick a bird from their aviary. All plants are real and in everyone's rooms. These are very active nursing homes. Lots of social function going on. Just a lot of fun to be in. And we were always told, when I do tours of Eden Alternative homes, or Edenized homes, you be prepared to lose 30% of your staff immediately, because they don't want to take care of animals. Well, I was talking about this one day recently, and a Jamaican nurse aide said, wait a minute, that's not what that's about. What that's about is if you have Jamaican nurse aides, and they leave, it's because in Jamaica, we do not permit animals in the house. That is a no-no, especially dogs. So it is just not in their cultural realm. It's not that, it's just foreign to them. So they would prefer to leave, and they do. But that's just one example of where culture, always be aware of the culture of the individuals. Language problems, and then communication between staff and residents and staff to staff. I've seen everything from no shift report. You guess what's going on with your residents every shift, because you're not going to get a report. They're gone, and that's everybody. Then I see in some homes, very hospitalized, routinized shift reports. Then I see nurse aides who come in a half an hour early and stay a half an hour late, and they have what they call little shift reports outside among themselves. And so you'll see all these different kinds of things going on. And they call it little shift reports. Now, there's an attitude in this too, which is also a challenge. And I'll give you an example. Lynn Snow, who is a geriatric psychologist, she and I had worked on a study while she was here. She's now at the University of Arkansas. And she went in, she wondered why pain management was so challenging in long-term care. She was in a lot of nursing homes downtown. And so she went in and she asked RNs, LVNs, and aides, how do you know someone is in pain? And the RN would say, well, I just go to the chart. The LVN said, well, I look at the chart, and then, I'll look at the facial expression. And the aide would say things like, well, when Mrs. So-and-so is leaning to her left, that means she's got another urinary tract infection. They're all right, but they don't talk to each other, and they don't respect each other. Because then they said, well, did you tell the nurse? Well, she doesn't listen to me. Now, these are some nursing homes, not all of them. But be aware that each one is different, and you watch the communication in each one. You watch the attitudes toward one another. Many are very, very hierarchical. In New York, I may have asked if there's some hierarchy standards in some of those homes where I'm going into, and they said, well, in New York, we call the nurses paramilitary. So it's interesting to watch. Watch the culture. The same with, if you're going to do a study in a nursing home, there's one of the studies I gave out was, it's called about falls. Well, there was this company has this technology. It's called Vigil. And you hook up all the doorways for high-risk elders who may fall during the night. And they had, it was all free to these nursing homes. They had control nursing homes, and they had where they were going to put all their monitoring devices. And they put them in the bathrooms, and they put them on the doorways. And what they wanted to do, the goal was, so the nurse aide wouldn't have to check on residents during the night. Well, you don't know nurse aides. They protect their residents. So what happened in that study is the residents that had all the monitoring devices, the aides checked on them twice as much. They sabotaged it because they know best. And you best understand some of this because you're working in a very different milieu. And so they realized then that the aides weren't going to, they were going to check on everyone. And the researchers said, yeah, but that's a burden. Not to the nurse aide, it isn't. And not to the resident. Do you know how many residents I ask, how do you know your aide or nurse cares about you? How do you know? Well, they check on me. It's that simple. The researchers didn't quite get it, the electronic book. So that was kind of interesting. Also, their voices weren't being heard. It's another attitude thing, I guess. Another group that I talked to in Illinois, there were the PT folks and the other professionals wanted to let a certain group of residents walk on their own. They don't need help. But the CNAs, they get really tight. Remember, 80% of their time is spent with these residents. Indirect care. No, we can't let that happen. Well, apparently they said, no, you leave these residents alone. They'll get along by themselves. They won't fall. And their attitude to me during a focus group was, we'll show them. We'll wait for the incident. We'll show them. And so I went back to the people and I said, you got to talk to each other. You have to negotiate. This is a team. It's a family. So it's kind of interesting. Attitude, hierarchy. Knowledge levels among staff are difficult. Many are not familiar with working with individuals with schizophrenia, bipolar, dementia. They don't know how to engage residents to help the resident or encourage them to participate in their own care. There's an attitude on some resident parts. I'm paying for you to take care of me. and they won't listen to the aide. So lots of interesting things. Barriers. Medical technology. You can't assume we all know that. In the Magacy study that I put on the bibliography, they studied health literacy of families and residents in rehab, in 2 nursing homes. These are post-stroke and hip fracture. And they asked them, and by the way, it didn't matter about college education. They still didn't know. They didn't understand cognitive impairment. They said, well, what does that mean? Well, they gave all these strange answers. Well, it means you're going bonkers and you're crazy all the time. Or these are the answers college-educated folks were giving because they don't know. We can't assume they know. They said, well, most information like decision-making was assessed from with the help of personal friends, family that are trustworthy, physicians, their own private physicians, and nurses that they knew. That's where they took all their information from and made all their decisions. Comprehension. When they were given certain quality indicators, they had no meaning to them. They were generalized, out there meaning. When asked about, well, what about this, there's so many pressure ulcers in this home? Well, their response to that was, that's because the nurses are so good at assessing them. See that misinterpretation, lots of misinterpretation. Why is there so much, why do you think there's so much delirium? Oh, because this nursing home was specialized in delirium. See that term? So it's very, very, very interesting. How do they make their choices of where to go, which rehab center, which nursing home? In this study, word of mouth, how close the facility was to their own home, and how much parking cost, because they didn't want their family to pay money to visit them. So everything has to do with meaning. What is the meaning to each individual person? The Lloyd study said other barriers: age, hearing difficulties, vision, language, anxiety. Again, I think I mentioned in the Hester study, they were looking at social communication skills and health literacy. If someone has trouble initiating a conversation, that can predict low health literacy because they don't know, how to ask the question. Their facial expression and the voice tone. You can these 3 things kind of predict how active or engaged someone is in their health decisions. So I think I'll stop. Well, no, I won't. I thought I was going to stop. The subjects did understand 2 things. They understood patient satisfaction and leave of absence. The studies also show that smaller facilities with more RNs had a better quality of care and more individualized care. And as far as access and understanding more about nursing homes, I would strongly suggest everybody visit, go to Google, and it's Nursing Home Compare. And you will get more information about long-term care, and if you want information about a specific home, it's there. You plug it in, and it will tell you all about that. It will also give you a checklist on things to look at for good nursing homes. I caution you here. Very structural. Okay, residents may have personal belongings in their rooms. Each resident has a storage place. These are very structural. That alone. Each resident has a window. Okay, let's go back to it. The exits are clearly marked. This is 3 or 4 pages. Residents have a choice of food items at each meal. Residents, including those who are unable to leave their rooms, may choose to take part in an activity. And then there's many safety residents. The nursing home has an emergency evacuation plan. Again, many of these are structural. I was having a discussion with several people the other day, and they were wondering, how do you know? I said, well, when you walk in, and it was an occupational therapist at the table, and she said, if people, when you walk in, if they smile and say hello and introduce themselves, huge indicator. When you see the staff be as family with residents, big indicator. So again, the barriers include the attitudes, include trying to understand aging in general. Upon admission, and I'll just end this question on this, upon admission, what I usually see in many nursing homes, the staff take over care. We're going to take care of her now. It's okay. What that does is remove the resident's humanity. Because as humans, we must reciprocate. You've got to give residents a chance to reciprocate. And in many nursing homes, it's the nurse aide who understands that. They may not use the word reciprocation, but they're the ones that are going into residents' rooms, having a conversation with them about their problems. Resident is giving them advice, and they're taking it, and they're coming back the next day saying thank you. I have never seen such happy residents as those who have that kind of relationship in long-term care. So again, a barrier would be the administrator who says, you've got tasks to do. You don't have time to sit and talk. That's a barrier.
Thank you, Dan. We have about 15 minutes left, and I wanted to,
Okay.
no, we're doing great. No, we're good. I think that we've more or less covered the first three questions. It's interesting because I'm thinking of health literacy on like everybody needs to understand health literacy in all populations and to improve quality of care and access to care. But it must be very different for a nursing home in terms of who do you talk to? Do you talk to the residents? Do you talk to family? Do you talk to staff? If there is an issue, if there's something that needs to be communicated. In prisons, who do you talk to? You talk to the correctional officers, the warden, the inmates. So I kind of want to get an idea of what process goes through the communication to the prisoners and then to the nursing home. So Jim, we're going to start with you for about another 5 minutes or so because I want to open it up to some questions if possible about that. How does communication work within you did a wonderful job in describing the barriers and the precautions that need to be taken. How is that translated maybe into communication for obtaining health care or some other issue?
One of the things that you have to remember is that even though the inmates have some communication difficulties sometimes, they do have an average IQ for the most part, but prison-wide, the level of education is maybe the 4th or 5th grade level. So providing information in very specific, concrete terms without acting like they're being condescending is very important. You got to give the information with a certain level of respect as well, because respect is very big. You need to link that behavior to specific health problems that is very specific and personal to them, so give them personal examples in their own life about what's happening, and break it down into very short steps. One of the barriers and one of the traps that the staff fall into is that all inmates lie, and they're just out to get something for nothing. And while this is definitely true for some, it's not necessarily true for all of them. In fact, most of them, when they come in for a health problem, they really do have a health problem, or at least they think they have a health problem. There is a problem that they want something done about. And so we have to kind of get over that barrier that all inmates lie. And those that are manipulating, don't make themselves known over time. We can deal with those and give them that. Part of the job is to educate them on how they help themselves instead of the idea that somebody else has to fix my problem for me. So teaching them how to fix their own problems, maintaining their own health is very important and necessary, and regardless of the health problem that they're relating to. And you can't assume that all the inmates are the same simply because they have the same diagnosis. The background and lifestyle differ. They probably brought the problem along from different avenues. And so it's very important to indicate those different avenues on the individual treatment plans and to take those personal differences into account. And lastly, perhaps most importantly, good rapport is essential. If they think that you're interested in them and that you have a personal investment in them, then they will respond more likely to respond positively to your suggestions and recommendations. They may not follow them all, they may not act on your advice regularly, but they're more likely to do it more often if you respond to them as a person than just as an inmate member. That's probably the major one.
Very good, Jim. Thank you. Diane?
Before coming today, I emailed many nurse practitioners from New York, Missouri, Illinois, and Texas. Said, tell me about your role. Tell me about your nursing homes or your role. Each one has a role in a nursing home. And in answer to this, one of the best, and I regard her as incredible, she keeps her door open all the time. She has a position in a very large facility, faith-based. That makes a difference. Faith-based, and she is the Director of Operations Excellence. Keeps her door open. And she allows, and I've watched this because I've been with her, so nurse aides are walking in and out and talking to her, having a conversation. It's that rapport that Jim talks about. It's incredibly important. And what she noticed, and again, this is noticing, being present to, attending to, she noticed a lot of the nurse aides were limping, had very poor shoes on, and then she realized they don't know foot care. So she brought all the nurse aides in and she gave them this wonderful in-service about self-care, foot care. And they didn't know. They did not apparently learn this from a textbook that when they got their certification. You can't assume that. But what happened after this was the foot care of all the residents went up significantly. So it's being creative. It's being attentive. It's noticing. Missouri has a wonderful, it's called the Missouri Nursing Home Tax. And two of my colleagues, Carolyn Siems and Marilyn Rance, incredible gerontology researcher, they have something called www.nursinghomehelp. Any nursing home in Missouri can call them and they will go as a consultant, and it's free because Missouri is picking up the tab. So you see, every state is different. So they have no problems with calling for help. Let's see, and then I wanted to just say, as far as what residents want, as far as in-services go, you'll see a lot more in-services in assisted living. But I think they should also be in all nursing homes. And among the in-services, most that these geriatric nurse practitioners came back to me with, they said especially assisted living, they love yoga, meditation, exercise, nutrition. So it gave them some control back once they understood more of that. And so that was a big help, how to deep breathe, how to relax. They like that. There's a 800-bed nursing home in New York City. On one level, in one unit, a professional percussionist went in and he did drumming. Well, they all heard about it. He says they can't get enough drums and they just love to drum. So there's, again, using, don't not treating it like a hospital all the time, but a lifestyle, health promoting lifestyles, different things that individuals are interested in. In long-term care, the average stay is 870 days. You have time to learn what's interesting to people and to get that rapport that we speak of. So again, I would say sit down with people. Just say, tell me about your day. That's all you have to say, and listen. They'll tell you.
Familiar theme,
Yeah.
listening and empathy.
Yep. Yep.
Thank you, Diane.
Oh, no.
We're pretty close. We have about 5 minutes. Before I open up the audiences for the different sites and to hear for some questions for Diane and Jim, I want to remind you all to please fill out your evaluation forms. The general one that's on the table, and if you have your CE request, you can give that to me or bring it by my office anytime. Or at the different sites, please contact your coordinators for each of the sites, and I appreciate all your attendance and participation. So right now, I'm going to open it up to here at UTMB as well as the other sites for any questions or comments. Yep, sir.
I have a question for each of the speakers. Start with Diane. About the eating concept, we know it's much better than the regular thing that we see in nursing homes. Why don't we have more of them? Is it more expensive to maintain? Do you pay more to the people that work there? Is the liability for the institution bigger and they have to pay more insurance? Having the pets, is it like a hazard to the other residents? Why don't we see more of those?
More of what?
Eating,
More
In
eat.
service?
More eating
Eating
alternative
nursing
types
homes,
Or
of.
more eating
Eating.
alternative?
eating
Yeah.
accommodation.
Well, it's a couple things. After a while, everybody said, hey, this Eden thing is pretty good. So what they did, they threw a cat in there and they go, okay, we're Edenized now. So Bill Thomas said, okay, that's not right. Let's certify Edenized nursing homes. And you have to get volunteer or you have to pay for a vet. And that's okay. Most vets volunteer. Every home that I know of, they have 2 vets that volunteer and back each other up. So it is different. It is different. But there's, and you will lose some staff, but the staff that come aboard love it. There is one nursing home, if you get a chance, it's here in Texas, it's by San Antonio, it's called the Eden. Not from the Edenized, but it was called the Eden a long time ago. I got there at 7 o'clock in the morning, too early. The whole place was, people were walking around their function, their ambulation. They're walking around with their dogs. They're talking to each other. There's arguments, get that cat out of my room. I mean, everything came alive. You have to be willing and to understand how wonderful that is. And there are a lot of places, you have to sell people on the idea. The greenhouse is another one. That's, again, Bill Thomas, where they'll place a home in a already established community, but it's got 8 bedrooms in it, and 1 very advanced nurse aide. And people come in and they eat at a table with a tablecloth, and they eat better. There was a very short film on the Greenhouse Project. They're wheeling this woman out of the nursing home, and she's saying goodbye, goodbye. She has not eaten by herself in 10 years. Within 24 hours, she's sitting at a table having a conversation with the other residents at the home, at the greenhouse, eating, and then the camera pans to her daughter and the administrator who are crying. We have to change these environments. One of the biggest helps that we have is the Pioneer Network. They are changing East Coast, North, Central, West Coast. It's got to come here. I see it all over the place. Culture change in long-term care is happening all over the place. I'm sorry we're a little behind the ball.
I heard there was another aspect of that is that they also concentrate on acknowledging the kinds of celebrations and days of holidays
Unbelievable.
for the culture. Cinco de Mayo becomes a big deal, that type of thing. Probably at the nursing home you described for Mexicans,
And the culture-
Hispanics only.
Yeah, and the culture change, it's all about person before task, relationships first. Nurses can sit and have conversations. it's a very, very home-like structure. That's what-
Yeah.
And my second question to, what's his name? Sorry, Jim. What happens with a prisoner that becomes severely dependent? Like he cannot, incontinent, like he needs help feeding himself. What happens? Where does that prisoner go?
Jim, did you catch that question?
Okay. All right, can you hear me now?
Yeah, uh-huh.
Okay. The severely disabled inmate will go to a hospital setting or some specialized setting. And, for example, in Springfield, Missouri, the federal hospital there has a unit for geriatrics to a certain extent.
Yeah.
It's not just geriatrics, but that's where a lot of them wind up. And so it's more of a place where they can get day-to-day hourly care.
One that doesn't have the same security type of things, too.
There's no like nursing homes for prisoners or SNFs?
Some states are going to develop some prison nursing homes, so to speak. So it may be a wing at a prison that's separated from the other inmates. But those are still few and far between. It's one of those things that we're advocating, but the cost factor is until we get enough inmates in one location. And then, but there's a lot of security issues that go along with that as well. So at this time, they have to be very severely impaired, and then if they are, then they have to go to a place that has the medical resources in order to use the hospital.
Interesting. Well,
I would think state hospitals might be a possibility, but there are in New York at one time, there were 26 state hospitals. Now there are, I think, almost none. So, like with the geriatric population that have been long-term schizophrenic, they are going into nursing homes among staff that are not familiar with management.
Yeah, an interesting thing about the state hospitals, I read a study where in the 1970s there was 210,000 residents in state hospital and 90,000 mentally ill in prison systems. And the same study was replicated in the mid-1990s, and there were 250,000 mentally ill in hospitals, in prisons, and 90,000 in state hospitals.
wow.
It's reversed.
Wow. Any other, thank you, Jim. Any other questions or comments or anything anybody wants to make? Any here? Any of the other sites have any other questions or comments? Well, it's been a wonderful 3 hours, I think. I haven't heard any clapping, but I want to give everyone a real thank you for all.